Hi, this is Dr. Sherpanini. The topic for today is migraines. We're going to discuss migraine headaches. I will go over the definition, what is a classic migraine, differentiate different types of migraines, go over some treatment options. According to International Headache Society, migraine headache definition includes experiencing headache attacks at least 5 or greater in a 24-hour period, intensity of moderate to severe, localized to one side of your head, can last between 4 to 72 hours, and it's worsened with strenuous activity like exercise. Additionally, patients experience a throbbing or a pulsatile-like headache. It tends to be associated with nausea. Patients experience sensitivity to light, sound, whereas in contrast, tension headaches are quite the opposite of a migraine. So some of the main features of a tension headache include a duration of headache tends to be longer than migraine headaches, somewhere between 30 minutes to 7 days. It usually appears on both sides of your head and does not include qualities like pulsatile or throbbing. Intensity tends to be lower than migraines and is usually not associated with nausea. But tension headaches can include one of the sensitivities like light or sound. A classic or complicated migraine is actually described in phases. People recognize a classic migraine in the form of a prodrome phase or a pre-symptom phase, where patients start to develop symptoms like fatigue, mood changes, irritability, depression, constipation, neck pain, stiffness, frequent yawning, usually lasts 1 to 2 days. Then followed by aura, which can last somewhere between 30 to 60 minutes. Auras are a manifestation of our nervous system. Following auras, which can precede a migraine attack or sometimes can happen simultaneously during a migraine attack, a patient starts to develop migraine attacks again focally, localized to one side, throbbing in quality, can last anywhere between 4 to 72 hours. Following resolution of the headache, patients may experience a post-drome phase, which is basically almost a relapse of some of the symptoms that they experienced before the headache, but somewhat a release of those symptoms in a gradual fashion. So patients are somewhat getting back to normal slowly. This can last up to a day. During the post-drome phase, patients start to feel more exhausted. While the mood is gradually recovering to baseline, their GI system will also start to reverse course and regain normal appetite, bowel function. Alright, let's go back and talk about auras. Migraine headaches can be preceded by a nervous system manifestation called aura, which is usually a visual manifestation in terms of symptoms that they may experience, like change in vision, squiggly lines, floaters, flashing lights, blind spots, even temporary loss of vision. Not all auras are visual in quality. Some auras can also manifest as sensory loss or tingling sensation in your arms, face, or even present as loss of strength in your body part on one side, which may mimic stroke-like symptoms. To summarize, auras can present in the form of sensory deficits, motor deficits, or visual deficits. Generally last between 20 to 60 minutes. Auras can occur by themselves without a headache, often known as migraine without a headache. I think some understanding of terminology associated with migraine headaches can be very useful in determining what type of headache are we talking about. When a person is experiencing a complicated migraine, we just described the 4 stages of a complicated migraine, which is a predrome or prodrome, aura, a migraine attack, then followed by a postdromal phase. When a migraine headache is not associated by a prodrome or an aura, we call this a common migraine. When a migraine is associated with motor deficits in the form of auras like loss of sensation and strength on one side of the body, this would be described as a hemiplegic migraine. Migraines that only include auras without headaches are called migraine without headaches. Migraines that include temporary loss of vision on one side or have flashing attacks or visual deficits on one side are referred to as ocular or retinal migraines. Migraine attacks that happen more than 15 times a month are referred to as chronic migraines. Some common triggers that could lead to an onset of migraine can include abrupt changes in your sleep pattern, like changing your sleep schedule, sleeping shorter durations, or oversleeping, or sleeping at the wrong time of the day. Stress. Some patients experience migraines due to caffeine withdrawal, use of oral contraception, association with menstrual cycle. Screen time, tobacco use, exertional workouts, dehydration, and certainly exposure to sounds, chaos, noisy areas. Food has also been known to be a trigger of migraine attacks. Some food items like chocolate, aged cheese, and consumption of alcohol, food items with tyramine have been shown to trigger migraines. So when it comes to treatments, we just want to break down treatments in the form of acute, prophylaxis, and treatment of refractory migraines. In the acute migraines, the goal is to abort these migraines. Some important drugs to remember when addressing acute migraine attacks are non-steroidal anti-inflammatories like naproxen, ibuprofen, triptans like sumatriptan, rizatriptan, and combination meds like aspirin, caffeine, Tylenol, or sumatriptan with naproxen. Now, also treating the underlying triggers and associated symptoms like nausea is extremely important. Triptans are often prescribed to treat migraine attacks due to the belief that migraines are a result of a vasodilation of cerebral vessels, and by constricting these vessels through triptans, we're able to counteract migraines. Triptans act on 5-HT1D-BF receptors in the smooth muscles of these blood vessels. Clinical studies suggest that triptans are more selective for migraines and cluster headaches. In patients who don't respond to the oral form of triptans due to nausea or other factors, we can administer triptans in an alternative route, like subcutaneous nasal sprays or by suppositories. Some key points to remember about triptans are to limit usage to less than 10 days. They should not be used in patients who are having symptoms of strokes or cardiovascular disease like ischemic coronary disease, peripheral vascular disease. Triptans are often only reserved for acute migraine attacks. Other contraindications include concomitant use with SNRIs like venlafaxine, also usage with monoamine oxidase inhibitors simultaneously or within 2 weeks of recent monoamine oxidase inhibitor administration. Prevention is usually recommended when a person is experiencing frequent attacks and is currently disabled by their symptoms, circumstances, or are currently suffering through addictions like opioids, who may have tendency to suffer migraine attacks. A preventive strategy should always be tailored to a patient's individual clinical factors. For instance, a doctor may review your comorbid conditions and the medications you're currently taking to evaluate for opportunities to introduce new medications that could either complement your current regimen or replace your existing medications to improve the overall efficacy of your care. Some medications used for prevention include blood pressure medications. They're categorized as heart rate slowing drugs known as beta blockers or calcium channel blockers. Some examples include metoprolol for beta blockers and verapamil, for instance, for calcium channel blockers, antidepressants like amitriptyline, imipramine, fluoxetine, sertraline, seizure meds like topiramate or Depakote. Also, some unconventional treatments that have been tried include Botox injections, vitamin infusions, herbal supplements, magnesium salts, etc. Not all patients respond to the strategies that we just went over in acute and preventive care, and these patients are described as refractory patients who need more unconventional treatments. I often will look for help from neurology to assess these type of patients. Migraines can be debilitating. Patients who suffer from chronic migraines or those who fail traditional medications described in acute and preventive categories often need a multimodality approach through help from neurology, pain clinics. Medications like long-acting opioids, stimulants, Botox injections may be necessary to alleviate the suffering. I'm posting some links to find more resources regarding migraines and management of headaches. Thank you.